I, Dr. Fayaz, final year resident here at Teaching Hospital, presenting on behalf of Dr. Ahmed, the factor responsible for depression in patients with COPD. As we all know, it is a neglected but important health problem. Accounts for significant morbidity and mortality worldwide by year 2030, expected to be the third leading cause of mortality. COPD exists as a heavy and increasing social and financial burden. The medical therapy for COPD has made very little improvement, so patients still deal with frequent acute exacerbation, lengthy hospital stay, low survival rate, and impaired physical performance and quality of life. The patient with COPD has a significant rate of depression than the general population. The patient with COPD often go undiagnosed and untreated for depressive illness in both primary and secondary care, despite evidence that some interventions such as antidepressant medication, pulmonary rehabilitation, and counseling can improve the quality of life. The impact of COPD on motility and disability adjusted life year is substantial, with estimated range ranging from 6.6 to 7.7. The previous study found that from 6 to 56% of the people with COPD also have experienced depressive symptoms. The symptoms are strongly linked to the decline in the functional status, quality of life, disease progression, and motility. The patients suffering from depression are at risk of not completing their prescribed medication management programs such as pulmonary rehabilitation and quitting smoking. The clinical outcome is negatively affected by depression, and admitted patients have higher admission and relapse rate and place a greater financial strain on the healthcare system. In addition to being an independent predictive factor for death in individuals, COPD depression is linked to frequent hospital readmission for acute exacerbation. Reduced functionality due to COPD may contribute to development and maintenance of depression. The age, gender, employment status, living alone, and steroid use are just few of the characteristics that have been linked to depression in COPD patient. Due to the irreversible nature of the disease, the goal of treatment is not to cure the disease, but to alleviate the symptom, boost functioning, and boost quality of life of the patient. So the patient with COPD often experience substantial physical disability and unpleasant symptoms, including dyspnea and productive cough, and have long been hypothesized to suffer from depression. Depression is a negative impact on quality of life and can affect a person's emotional, social, and even physical well-being. The material and the method descriptive study was done at Cyber Teaching Hospital Pulmonology Unit between 12 November 2019 to 12 May 2020. The sample size was 43, keeping 87.5% proportion of heavy smoking as respective of depression in patient with COPD, and 95% confident interval and 7% margin of error. The conjective non-probability sampling technique was used. The patient with COPD fulfilling the inclusion criteria as per board criteria and spirometry finding. The depression was defined as any patient having a score of more than 7 according to 21 Hamilton Depression Rating Score. Inclusion and exclusion criteria: the patient with COPD with depression has per patient definition, both gender, male and female, and the patient age between 40 to 80 was included in our study. The exclusion criteria were the patient having the intellectual cognitive impairment and mental illness other than depression, anxiety, OCD, bipolar disorder, and family history of mental illness. Patient with a history of other pulmonary diseases like asthma, bronchitis, ILD, post-TB, and pneumonia. The patient with a history of CCF, ischemic heart disease, and hypothyroidism. All these patients were excluded from our study. The data collected after ethical approval from the hospital ethical and research committee with informed consent was obtained from all patients. The patients were assessed according to 21 HDRS scale for presence of depression. All the information pertaining to age, gender, factor of depression such as low socioeconomic status, stage of COPD, dyspnea scale, smoking history, and quantitative CRP were recorded. All patients COPD with the duration of COPD in year and number of hospitalizations per year are the potential effect modifier were also recorded in a pre-designed structure pro forma. Age and gender was certified in LS to see any effect modification. The pie chart shows the male and the female distribution. The 43 patients were included in our study. The minimum age was 40 years and the maximum was 40 and the maximum was 80. The 43 patients, the 19 were male and the 24 were female, as shown in the pie chart. The mean age was 61.93, with a mean standard deviation of 10.3. And the mean age was 60 years. On the basis of age, the 43 patients were divided into two groups. The 25 patients were in group 1, that is between age 40 to 60, and 18 patients were included in group 2, that the patients were between 60 to 80 years of age. Among 43 patients, the 29 patients had 1 to 10 years of COPD duration, and 14 were having more than 10 years of COPD. The patients were also distributed on the basis of number of hospitalization. Among 43, the 13 patients, 16, 21, and 3 patients were having history of 1, 2, 3, and 4 times hospitalization respectively. The patients were also stratified on the basis of spirometric grading stage of COPD as well. The 43 patients, among the 43 patients, the 7 patients were having stage 2 COPD, the 25 were having stage 3, and the 11 patients were found to have stage 4 of the COPD according to the spirometric grading. Among the 43 patients, the 16 and 27 were smoker and non-smoker respectively. The COPD patients were further stratified among gender with smoking. Among male, 21 and 7 were smoker and non-smoker, and the female patient, the 4 and the 20 were smoker and non-smoker respectively. Smoking was also stratified on the basis of age of patient, duration of COPD, and number of hospitalization. Among the 43 patients with depression, the 29 were poor. Their monthly income was less than 20,000 Pakistani rupees per month, and the 14 was having greater than 20,000 Pakistani per month. The socioeconomic status was stratified on the basis of gender, age of the patient, duration of COPD, and number of hospitalizations.
Please show the conclusion. Thank you.
The conclusion of the study was concluded that the low socioeconomic status, board state of COPD, smoking history, and increased CRP level and increased dyspnea level were the factors leading to depression in COPD. Any of them act as an independent or clinically important factor for depression in COPD and thus affect quality of life and outcome of the patient. The recommendation of our study was to further studies comprising of large sample size are recommended to elaborate the contribution of each of these risk factors. The further work to correlate each of them, the factor with the depression also recommended.
Thank you, Dr. Fayaz. Thank you for a very important study. You can take your certificate.